From the American Association of Nurse Practitioners, I'm the host of today's special edition episode, Nurse Practitioner and Director of Education, Eve Roberts. And this is NP Pulse, the voice of the nurse practitioner. Welcome to NP Pulse, AMP's podcast bringing you unique nurse practitioner voices and expertise on issues that matter to NPs and our patients. As always, be sure to subscribe to this podcast, share with your colleagues, and check back often for new conversations with nurse practitioners and healthcare leaders from across the nation. Today's episode is in partnership with Practicing Clinicians Exchange and is supported by an independent educational grant from GSK. Our objectives for today's CE podcast, listen up, time to prioritize RSV vaccination for adults, are as follows. Number 1. Counsel vaccine candidates on risk factors for severe RSV disease. Number 2, incorporate the latest RSV vaccine recommendations into clinical practice. Number 3, identify and implement strategies to improve RSV vaccine uptake across diverse populations. Respiratory Syncytial Virus, RSV, significantly impacts adults, especially those over the age of 60, and those with chronic conditions. In this podcast, Drs. Carrico and Stevenson discuss the underestimated burden of RSV and explore practical strategies for increasing vaccine uptake that you can apply to your practice starting today to protect your patients against RSV. Dr. Ruth Carrico is a family nurse practitioner and senior consultant with Carrico and Ramirez focused on infectious diseases, infection prevention and control, and vaccinology. She is based in Louisville, Kentucky, and is a professor, adjunct faculty with the University of Louisville School of Medicine, Division of Infectious Diseases. Dr. Carrico has received training specific for Healthcare Epidemiology at the Centers for Disease Control and Prevention in conjunction with the Rollins School of Public Health at Emory University in Atlanta and the Society for Healthcare Epidemiology of America. Dr. Carrico has worked in the field of infectious diseases and infection control for more than 30 years. Dr. Carrico also maintains a clinical practice focused on vaccines, vaccination, and immunization processes. Dr. Audrey M. Stevenson is a family nurse practitioner with over 40 years of clinical, public health, and leadership experience. Dr. Stevenson, who holds a Master of Public Health and Master of Nursing degrees, received her doctorate in public health from the University of Utah. She formerly worked in public health for over 34 years and was the former Division Director of Family Health and Clinical Services of the Salt Lake County Health Department in Salt Lake City, Utah. She currently works as a consultant and teaches graduate FNP and MPH students at 2 universities. Dr. Stevenson is also a member of the statewide Vaccine Advisory Board, where she collaborates on vaccine policies and recommendations for the state. Previously, Dr. Stevenson served as Vaccine Branch Director for the COVID-19 Incident Command for Salt Lake County, where she directed the vaccine strategies for 1.2 million residents of Salt Lake County. She's been a vaccine champion for over 30 years. It is my pleasure to welcome our nurse practitioner experts, Audrey and Ruth.
Thank you for that kind introduction, Eve, and thank you to everyone for joining Ruth and I today to discuss this important topic. I want to start by talking about the burden of adult RSV. How do we explain the risk of RSV and severe outcomes to our patients? Well, the burden of RSV in adults is substantial and likely underestimated due to the lack of testing. It's really difficult to differentiate RSV from many of the other respiratory viruses without diagnostic testing. However, it's estimated that each year in the United States among adults aged 65 years of age and older, RSV leads to 60,000 to 160,000 hospitalizations, 6,000 to 10,000 deaths. And when compared to influenza and COVID-19, the number of hospitalizations and deaths are lower for RSV compared to COVID-19 and influenza, but the severity of RSV is similar or worse. In a recently published multi-center cohort study, the odds of invasive mechanical ventilation or in-hospital death was similar for RSV, influenza, and COVID-19 among unvaccinated adults. The odds of invasive mechanical ventilation or in-hospital death was significantly higher for unvaccinated patients with RSV compared to vaccinated patients with COVID-19 or influenza. Some studies have shown that RSV in association with more severe disease and poorer outcomes, things such as longer hospital length of stay, greater ICU admissions, and higher mortality at 1 year compared to influenza. The presentation of RSV varies significantly among our patients. Severe disease can lead to respiratory failure and even death. Severe disease is more common in older adults, particularly our patients 75 years of age and older, and those with chronic conditions such as heart and lung disease and immune compromise. Ruth, talk to us about the disparities in RSV disease incidence and outcomes.
Audrey, thanks. That was a great overview that really helps us recognize the severity of disease and how much we need to respect this respiratory viral illness. And I think as nurse practitioners are present and leading healthcare and care decisions along with our patients in virtually every setting, it's important that we recognize the impact on the entire population. And as you mentioned, this involves then recognizing that RSV does not impact all of our patients the same. So we know that we will oftentimes have patients from minoritized groups, such as racial and ethnic minorities, as well as those that are in lower socioeconomic groups. And it is these individuals that are likely to also have chronic medical conditions. Also, these may occur at younger ages or many times even be undiagnosed. We know that individuals with chronic health conditions may also have no health insurance coverage or have difficulty accessing health care at all. Those individuals may also be more likely to be hospitalized. They visit emergency departments more frequently and unfortunately experience those catastrophic health conditions relating to RSV, up and including death. These groups are also more likely to be diagnosed with RSV just due to those factors such as living conditions or social environments. And when RSV occurs in these individuals, it is more likely to be severe. So this serves as a reminder that RSV is an equal opportunity type of illness. But we need to make sure that we as healthcare providers recognize that not all individuals are going to be impacted the same. So being on the lookout for this among our patient population. Now, I also want to bring up the importance of testing. Now, in the past, we know that really prior to 2014, before we had a reliable RSV test, many times we ended up lumping this into those, I don't know what you have, I can't identify it, but it is a problematic respiratory illness. Well, now that has changed. And so RSV as a disease may be on the radar for our clinicians. And this is, unfortunately, as I mentioned, different from what may have occurred prior to 2014 when we had a reliable test. But we need to make sure that we realize that a test now is available and we need to make sure that it is no longer underused. We now have commercially available combination tests and even CLIA-waived over-the-counter tests. So this is important for us to recognize then the opportunities to diagnose. Unfortunately, however, we still have no treatment for RSV, so sometimes we fall into that habit of saying, well, without an intervention, I don't really need to test. But I think all of us are increasingly realizing that it's important that when we can understand the etiology of a respiratory pathogen, and therefore that lets us know what is present, what is not present, what is worth treating, what is not worth treating, and helps us do what the Infectious Diseases Society of America, or IDSA, has really helped us recognize that, we need to use our treatments appropriately. That means not only treat appropriately, but withhold treatment, particularly antibiotics, which we know are not useful for a viral infection. Withhold those appropriately. So this makes testing as an important consideration. So just some basic guidance that we have from the IDSA is that, when you are looking at a disease during its season, test in high-risk patients when they are symptomatic. Again, when we are in season for that respiratory illness, test patients with acute respiratory symptoms in either those that are experiencing exacerbation of chronic medical conditions or if it is unknown. So, for example, when we're looking at influenza, we're looking at, understanding the presence of that infection and looking perhaps for the development of consequences such as pneumonia. Same thing for RSV. When we're outside of the RSV season, we want to consider testing in patients that have acute respiratory symptoms, again, primarily so we know what this may be and then rule out then what it may not be. So some take-home points is, I think, looking both at the information that you provided, Audrey, as well as our questions about health disparities, presence of disease, and testing. Make sure that we have in our toolkit an awareness of RSV as a potential etiology of infection as our patient is presenting to us. Use testing as part of diagnostic stewardship, when to test, when not to test, and then how that drives our decision making. And then use positive test results in practice, and it really serves as a reminder about the utility of an upstream approach, and that is looking at how do we prevent these viral illnesses, and we do that through use of vaccination. So let me add, after we have talked a little bit about this, Audrey, how do you think many of your older adult patients are perceiving RSV? Do they have an awareness?
I believe that many of our patients think about RSV as a childhood disease. They've heard about it in grandchildren or in their children or the hospitalization numbers that we hear in the media. However, many of the adults that we care for in our practices aren't aware that RSV is a risk for them as well. So we're fortunate in that we have RSV vaccines that have been developed for adults. There are 3 vaccines that are currently available for older adults. 2 of these are protein subunit vaccines, which use the RSV pre-F. And if you recall back when we had the COVID-19 vaccine, it was the spike protein that was the target for those vaccines. Well, in the RSV vaccines, the pre-F is a form of the F protein that's present on the viral surface before it interacts with the host cells to cause infection. And this is the primary target for the neutralizing antibodies in those RSV vaccines. So the 2 protein subunit vaccines that we have available, there's RSV pre-F, which is a non-adjuvanted RSV vaccine made by Pfizer. And this vaccine is also approved for the use in pregnant women for infant protection. The second is RSV pre-F3, which is an adjuvanted RSV vaccine made by GSK. And as you'll recall, adjuvanted vaccines include a substance that enhances our immune system's response of the vaccine. These adjuvants help our bodies to recognize the vaccine's antigen and to stimulate a stronger, more effective immune reaction. And the third is a messenger RNA-based vaccine, which is mRNA 1345 made by Moderna. Our patients are concerned about vaccine efficacy, as we are as clinicians. In clinical trials, all 3 vaccines were proven effective in preventing lower respiratory tract infections when compared to placebo. In emerging real-world data, in the first season after vaccination, the protein subunit vaccines were 75 to 82% effective in preventing RSV-associated hospitalization. We don't currently have data on the messenger RNA vaccines. In talking about vaccine safety, RSV vaccines are safe and well tolerated, and serious adverse events have been similar to those of placebo. But there's 2 topics that may come up with our patients. The first is atrial fibrillation. There was a numerical difference in the incidence of atrial fibrillation with vaccine versus placebo in phase 3 trials for the protein subunit vaccines. However, in a population-based propensity matched study, there was no difference between RSV vaccination and influenza or Tdap vaccination. The other topic has been Guillain-Barré syndrome, or GBS. In clinical trials, there were 2 cases of GBS that occurred following vaccination with the non-adjuvanted vaccine and 1 case following vaccination with the adjuvanted vaccine. So in January of this year, the FDA added a warning that post-marketing observational studies suggest an increased risk of GBS following vaccination. However, post-marketing evidence suggests increased risk, but currently not enough evidence to establish a causal relationship. We need to keep in mind that the risk of GBS is rare, and it's much lower than the risk of severe RSV disease. And we do see cases of GBS that occur naturally as a complication associated with viral illnesses. Ruth, I know that ACIP recently was able to meet. Talk to us about the Advisory Committee on Immunization Practices recommendations.
Thanks. I think, the ACIP recommendations become such an important factor for us in looking at how we are determining when and which patients meet clinical indication for vaccination. So we know that previously RSV vaccination was recommended for adults 60 years of age and older using shared clinical decision making. And all of us who have followed and continue to use those outlines and those tenets for shared clinical decision making sometimes found it to be overly cumbersome, and sometimes it was even confusing for clinicians to say, well, what is the difference between shared clinical decision making and the conversations that I always have with my patients? So the ACIP has recognized that this may have actually produced a barrier for the ability of the clinician to have the discussion. They viewed that as this is a required element. I'm not sure that I can do this, therefore I'm going to defer discussion, or I'm going to refer a patient somewhere else for vaccination. So I think ACIP was very wise in saying, wait a minute, let's do what we need to do to have these appropriate conversations with our patients that enable them then to ask the questions, have clinicians then approach conversations in a way that is relevant and conversational for them during their patient encounters. So I was really happy to hear that. So our current ACIP recommendations are, we have an age-based recommendations for all adults that are age 75 years and older, and that we do not then have a focus or a requirement for shared decision-making. We talk with our patients like we always do. So 75 years of age and older, that vaccination is appropriate under the age-based recommendation. Well, what about individuals that are younger than 75? Well, we have risk-based recommendation for those patients 50 to 74. So that age was lowered by the ACIP. Some of you may remember, well, wait, wasn't it 60? Yes, it was. But the ACIP recognized that, as I mentioned earlier, we have some of these health disparity issues, that we will see disease in some individuals within our community based on not only race and ethnicity, but also it is based on poverty. So we're looking more closely at what are the medical conditions of our patients? How able are they to access healthcare? How do some of these barriers then represent and present then a risk factor for RSV and those negative health outcomes that occur? So the ACIP said, all right, recognizing that, let's look at then a risk-based recommendation for individuals 50 up through 74. So we then use our knowledge about the patient and their underlying medical conditions, and then have that conversation with them about appropriate use of vaccination and patient acceptance. So again, we are not tied to shared decision-making. Instead, we're looking at what is the risk and benefit with our patient. We are, of course, having an ongoing conversation with them, but we're looking at what risks are present in our population. So as I mentioned, that's a risk-based recommendation for 50 to 74. And these risk factors include conditions such as chronic cardiovascular disease. So for example, heart failure, but specific or isolated hypertension is not included. But those that have chronic cardiovascular disease, chronic lung or respiratory disease, end-stage renal disease, diabetes mellitus, patients that have neurologic or neuromuscular conditions that cause impaired airway clearance or respiratory muscle weakness, that is a recognized risk factor. Chronic liver disease, chronic hematologic conditions such as sickle cell, also a risk factor. Our patients who experience severe obesity, that means a BMI 40 or greater. Those who are moderately or severely immunocompromised, also risk factors. Here's another one that I think is really important for our NP audience, And these include individuals who are living in a nursing home. And I know many of our NPs are leading care in long-term care facilities. So this is an opportunity for NPs who are seeing and are either providing primary or specialty care for those that are residents in a nursing home. Remember, they are in this risk factor list, age 50 to 74. Other chronic medical conditions should also be included. You may have patients who are frail, but they do not have some of the recognized health conditions. Frailty itself then is recognized as a risk factor. So that means we need to know our patients. We need to be thinking about, where do they live? Maybe our NPs are providing care in rural communities where escalation of care would be difficult. Then remember, we have an eye toward prevention. So provision of this vaccine. If we have a concern about an undiagnosed medical condition, again, think about prevention of RSV as important. So kind of summarizing this, it's, I think, important for us to remember it is recommended in our individuals aged 50 to 74 who have any of that relatively long list of risk factors that I went through. So it is a risk-based recommendation for that group. Once you reach age 75, we consider that you in all likelihood have that. We know age is the strongest risk factor for developing these complications from respiratory illnesses. So once you reach age 75, you automatically win the prize for that discussion about vaccination. So we know that we have FDA approval for the vaccine, but we also may not have ACIP recommendations for some age groups that fall below that age 50. So we will follow then what happens with ACIP for other discussions. But let's talk about individuals who may have risk factors for severe disease and are in that age bracket below age 60. So we know that we have the non-adjuvanted vaccine that is approved by the FDA, but again, without the ACIP recommendation for those aged 18 to 59 who are at increased risk for severe RSV disease. Then we have the adjuvanted vaccine that is approved for individuals 50 to 59 at increased risk of severe RSV disease. So I think kind of a take-home message here is it's important for us to always be aware of what we have in our recommendations from the ACIP. That is where we have the most firm guidance that is readily available to us. But as we continue to look at our population, we may have approval by the FDA for use of that vaccine in lower age groups. And we may keep our eye on that. But I think for many of us, we go to what we are seeing in our ACIP recommendations and then wait for firm guidance to help us be able to provide vaccine and vaccine recommendations specifically. But keep in mind those younger populations, certainly more is to come. So Audrey, what about some timing of the use of these vaccines? When should we provide it then for our patients?
Well, obviously, we want to ensure that patients are receiving this vaccine prior to the onset of disease within their communities, just as we do for influenza and COVID-19. The ACIP has recommended that RSV vaccination can be offered year-round. We want to make sure that individuals are being vaccinated before we start to see disease within those communities. So vaccination is most beneficial if administered in late summer or early fall, maybe between August and October or just before the RSV season. And we're going to have to be a little bit cognizant of that because our patients may not always come in during those fall months when it would be best to provide this vaccine. There is seasonality of RSV with some variability that's based upon the region that our patients live in. Generally, in the continental United States, the RSV season starts in the fall and it peaks in the winter. We think about the RSV season basically between October and April each year. Now, I'm already starting to have patients asking about whether or not they're going to need a booster of this vaccine. Likely, there will be a need for revaccination, but the interval has not yet been determined. And we found in the information that protection persists for at least 2 years with this particular vaccine. Ruth, tell us a little bit about how well we're doing with regard to RSV vaccine uptake in the U.S.
Thanks, Audrey. Well, I think, all of us would love to be able to say that we're going great guns with vaccination and acceptance, but we know that still this is a relatively new vaccine in its availability. So it's going to take our healthcare providers time to be able to reach the entire population who is eligible, meets indication, but also to be able to address conversations that our patients are having and their questions that they are having regarding the vaccine and the appropriateness for them. So, the CDC provides us with some great information through the National Immunization Survey. And this is specific outreach to individuals, a verbal telephone survey that gets feedback directly from our U.S. population, a sampling of our population. So some of the results I think are very interesting for this particular vaccine. So information that was available as of March 8th of 2025 showed that only about 47.4% of adults aged 75 years and older had reported ever having received an RSV vaccine. Now, it's important to remember that this survey asks for the patient to provide the information. So certainly there's going to be some recall bias, but it lets us know that in terms of providing the vaccine, our glass is not yet even half full. Interestingly, only 35.8% of adults aged 60 to 74 with one of those high-risk conditions that we have previously mentioned reporting having received an RSV vaccine. So this tells me a couple of things. Number one, that are we as clinicians identifying those patients with risk factors, and are we letting them know about the availability of that vaccine? And on the other side of the coin, are our patients who are experiencing those risk factors, are we conveying information in a way that they can understand and accept and internalize and then realize that it may be important for them so that they go on then to receive the vaccine? And then, of course, the third part of that is the vaccine available and accessible to individuals in the event that they are ready to be vaccinated? Also, we know, as I've mentioned earlier, we have disparities among individuals who are eligible for vaccine and appropriate in terms of preventing disease. And we know that vaccine uptake, unfortunately, is lower among patients who are in some of these lower socioeconomic groups, as well as those who may lack health insurance or healthcare access for a variety of reasons. Now, we know that there are differences in RSV vaccine uptake based upon race and ethnicity. And let me give you a little bit of information about that in those groups. Among individuals that are 75 years of age and older, vaccine uptake is lowest among our Hispanic and Black patients. Under the age of 74, vaccine uptake is lowest in Hispanic patients. And until recently, it was also lower in Black patients compared to Asian and white. So this is a reminder that as NPs are seeing patients not only across the lifespan, but across all of the race and ethnicities, it's important for us to be thinking about that in our vaccination discussion. So there's still a lot of work to do to ensure that all of our patients have equal opportunity for protection that can be provided by this vaccine. And then we need to make sure that all NPs in all settings, both primary care and specialties, are discussing with our patients this vaccine, the importance of this vaccine, and what it can do for them in order to optimize the uptake. So now that we know we have great vaccines, we have a lot of utility of that vaccine, we have challenges in addressing patients for whom the vaccine is appropriate, we have a lot to do in some of these practical strategies to help increase the RSV vaccine uptake. So we know that when we implement risk-based vaccine recommendations into clinical practice, that can be quite challenging because we have so much on our plate. But we know that prioritizing vaccination, access to vaccination, and the discussions regarding vaccines, both in terms of our patient interactions in primary and specialty settings, this takes very much a targeted approach, and we've got to remember to bring this up. Maybe we have decision support opportunities, or maybe we have standing orders, or we have other approaches in our setting. But we know that all healthcare providers should access the immunization status at every opportunity, and this means at every clinical encounter, acute care, preventive healthcare visits, everywhere where we are seeing patients. So How we do this, I think, is important. How do we identify our high-risk patients? How do we begin to have these conversations? How do we develop some of these individualized vaccination plans? So, Audrey, with your experiences, both in public health, in research settings, in practice settings, I'm interested to hear what you are doing to help identify our high-risk patients and enable them to receive vaccination. Well, what can we learn from you?
One of the important strategies is going to be having everyone on board within the entire practice, so that we know that when the patient is coming in that have certain conditions or fall within one of those age-based risk groups, we're going to flag those records within our electronic medical record system. We're going to use prompts looking at the chart so that everyone from the front desk that is checking the patient into the MA or the nurse that is working with the patient to the clinician, that all of us are looking for those opportunities to identify those individuals that would benefit from this particular vaccine. I think that it's also very important to make sure that we're providing education to patients as they're coming in, because we may be unaware of a certain condition that if we're not seeing the patient on a routine basis. And so making sure that we're looking at all of those opportunities to provide this preventive medicine and to provide this protection in terms of this and other eligible vaccines. What have you been doing in your practice?
Yeah, I think, that your comments are spot on in that, that RSV is a disease of breathing, just like influenza, just like COVID, just like, bacterial pneumonia. So when we think about the importance of this in conjunction with other respiratory illnesses, that does need to be top of our mind. And so whatever our approach is, whether, again, we are using decision support through our electronic medical record system, I think all of us realize that if we can have a prompt, that is much better than trying to rely on our memory. But you also mentioned, I think, something really important, and that is we need to make sure that our entire office is working with us for the good of the patient. So that means, no matter what preventive approach we're talking about, the patient recognizes that we, like they, want to prevent disease at the earliest opportunity. And so every person in our office has an opportunity to make that difference. And there are so many resources that we have available in helping to implement an individualized vaccination plan. I know I, like you, love immunize.org. That is a great website to go for tools such as, helping us look at standardized orders, helping us with education among those within our practice setting. But we realize that, our plate as a provider is very full. And so how do we make sure then that our office speaks for us and that we're using every opportunity for individuals to have those conversations with patients about how to make the discussion personal for them. So, as we look at making effective vaccine recommendations, we know that a provider recommendation, a strong provider recommendation, is a main reason that patients receive vaccination. And I will tell then, many of my colleagues and others that please remember our patients hear our words, but they hear our silence just as loudly. So if we don't bring it up, if we don't have the conversation, then our patients may incorrectly assume that vaccination is not important for them. So we have to be very conscious about how we are messaging. And I think all of us realize that maybe some of the words that we used before our COVID pandemic, that those no longer resonate with our patients, that we are having very different conversations with our patients now. And our patients want to know, how I understand, that yes, we have population-based recommendations, but what about me? As your individual patients, how does this impact how I approach the conversation? So we're using very different words. We're framing our messaging very differently. We're looking at our potential gains rather than risks. And we're using then biases, recognizing that we may have a bias for or against a particular vaccine or approach, but that may not be relevant for our patients. So we're having to really recognize how we are approaching this, as well as what is happening on the part of our patients and maybe what they have encountered on TikTok or other social media channels, and how that is influencing their approaches. So I like some of these frameworks that have become increasingly popular. And I want to use the 5 A's as one that really helps me to ask my patient, ask them where they are with respect to their approaches for vaccination. That helps me begin a conversation where the patient is. So instead of, maybe launching into a discussion and thinking about where I would start, I'm trying to elicit from the patient, where is their starting point? So I'm asking them more questions. I'm advising them. I'm helping to make sure that they understand the importance of risk benefit. What are their risk factors and how the vaccine may benefit them? I'm really assessing where they are coming from, what their concerns are, what their approaches are, what their fears are. And I'm using that then to assist them to meet the goals of a plan that we develop together. So it's not all about what I recommend, what I think. I'm trying to take what I think and help then blend it into what the patient thinks and what they feel. And after we know what they are thinking, then I'm trying to assist them with getting across the finish line for vaccination. Now, I may be a vaccinating office. Maybe I have vaccine readily available right there, and then I can assist them and arrange for vaccination. If I don't have vaccine in the office, then I'm looking at who are my community partners. Am I referring them to one of my pharmacy partners to receive vaccine? So I'm trying to, again, determine where is the patient in this discussion. That's my starting point. And then I'm reaching then across the aisle, to my patients so they understand risk and benefit. And then I'm trying to figure out then, how do we develop a personalized plan for them that includes accessing the vaccination? So, with that in mind, when I'm thinking about, it's not an easy discussion anymore, is it? And I'm having to use different words. Maybe my body language is different. Audrey, how do you normally recommend vaccination? And I want to look not only at how do you make sure that vaccine is available, but when we think about this as a respiratory illness, we know that we may be also recommending co-administered vaccine. I've got RSV, flu, COVID, maybe the pneumococcal vaccine that may be all relevant, and then other vaccines, maybe shingles vaccine is also relevant for that patient. How am I kind of balancing the counseling and the co-administration, and how am I bringing in all of that to the patient so we can recognize their hesitance, maybe their vaccine fatigue? Audrey, how are you addressing this in your practice?
Well, you've asked a variety of questions there that I think are really important. And I think that every visit that we have with a patient is an opportunity to be looking at those vaccines that patient may be needing. As you mentioned, at the time that we're wanting to administer the RSV vaccine, there's a number of other vaccines that we might consider co-administering. You mentioned, the shingles vaccine. There's also pneumococcal. There's the COVID. There's the influenza vaccine. And talking to the patient about which vaccines are most important to receive at that visit. And in some cases, it's safe to provide numerous vaccines at the same visit, but to be able to warn the patient about any potential reactogenicity symptoms that they may have, especially if they're getting an adjuvanted vaccine. So I think that it's important for us to provide those options to patients and see what works best for them, meeting them where they are. Trying to find out, what are their goals in terms of their preventive health? How can we best help them to meet those particular goals? I think that it's important for us to always be looking at any missing vaccines. Ruth, you and I have talked before about asking patients if they're up to date on their vaccines, and the answer that they always give us is, yes, I've received all of my vaccines. But when we start to drill down to the specific vaccine, okay, what date did you receive your influenza vaccine, or when did you receive your pneumococcal? and going through the specific vaccine, well, I haven't received that one, or I didn't know about that one. So we can't rely on the patient's memory on that. And unless the vaccine goes into the vaccine registry system, not all pharmacies and not all providers enter that information into the registry. And so the patient may not know that they have received a particular vaccine. So I think that we need to take the time to update the vaccine record, find out what vaccines the patient is needing. And with respect to RSV vaccine, patients may not be aware that there is a vaccine available to help to prevent this disease or the complications from this disease. And so having that discussion within the context of all of the preventive medicine that we're providing to that patient, or that anticipatory guidance that we're providing, is really going to be very, very important. What are your thoughts?
Yeah, I think absolutely. I think, earlier I mentioned that, less than half of the patients 75 and older who, should be considering this vaccine, 75 years and older, you are, age is the strongest risk factor. Yet we've only been able to reach less than half of that group. So I agree completely that, we will have, many of our patients that are not vaccinated simply because they are not aware. We haven't had the discussion with them. Others, may be concerned, about the vaccine. Is this something I need? Is it going to help me? Do I meet indications? So, it goes back to the strong recommendation from the healthcare provider and then making it real to that individual. Having those timely discussions, having those open discussions with them. And as you mentioned, knowing what they have and have not had. And I think this, can really circle back to the importance of having our office working alongside us. We are all in this together. And so I may need then to make sure that within my practice, there is someone who is updating vaccine information. It may be as simple as in your EMR, maybe you're just simply able to hit the reconcile button and pull information from your existing state immunization information system. For others, it may be a little bit more difficult. I'm in Louisville, Kentucky, and we are right on the border with Indiana. So I may have patients that receive some vaccines in Kentucky and some vaccines in Indiana. Well, I need to maybe go through some additional hoops to make sure that I can not only access the information on those two different state systems, but also then including the patient in the conversation. But as you mentioned, my patients don't always remember what vaccines they've had, or they get confused about what vaccines they have. So I can't always rely on what the patient tells me verbally, because if I go by what the patient tells me verbally and I enter that information as historic data into that immunization information system, if it's wrong, it's in there and it's viewed as the gospel. So, I have to realize, the limitations that exist in our information systems and how, information, a patient may be absolutely certain about what they have. I have one patient that loves to come to see me every year that will say, "Oh, Dr. Carrico, you're going to be so proud of me. I had my pneumococcal vaccine again." And I have to remind them that, it is the flu vaccine that is every year. It is now our COVID vaccine that for this individual is going to be more than once a year. Their pneumococcal vaccine is, depending upon the type of vaccine they've had, there are different series or schedules for that, but it's not something that they have every year. So I take that opportunity to educate them, but how much time do I want to spend bringing a patient down who is already excited that he's remembering to go and get his vaccines? I want to celebrate that success, but it's just a reminder that, I can't always rely on the patient's memory. So we know that this is a challenge and that we know we have multiple vaccines that we're going to be recommending. Many of them, as you mentioned, co-administration. I've got the patient in the office. I don't want to be, hesitant myself about recommending multiple vaccines to be given at the same time, because these are diseases of breathing. I can't tell what my patient is going to be around, when, or whom. So making sure that they have opportunity to receive vaccines that may be clinically important for them. But I know that we have patients that are hesitant. We also know that we've got patients that are tired of the conversation about vaccines. I know some of us clinicians, we're tired too. but we're trying to figure out how we continue to have these discussions about hesitance and fatigue. What are some of the approaches that you have in dealing with vaccine hesitancy and fatigue in your patients?
Well, and I think that the vaccine hesitancy and fatigue, especially the fatigue portion, can be clinicians as well. And so I think we need to recognize within ourselves that when we have a patient who is hesitant of vaccine, it's not the same as refusal. They may be hesitant about a particular vaccine and maybe not all vaccines. But what we need to consider is what is the foundation of their hesitancy? So one of the models that we can use in understanding vaccine hesitancy is called the 3C's of vaccine hesitancy. And this stands for complacency, confidence, and convenience. The complacency portion of this is the referral to a low perception of risk regarding vaccine preventable diseases. So many people believe that these diseases are rare or have been eradicated, which makes them less concerned about vaccination. I know in my own practice, especially with pediatric vaccines, that a lot of times the families would say, well, I don't want the child to get all of these vaccines at the same time. So which ones are the most important vaccines? Well, all of our vaccines are important, as we're seeing with the current measles outbreak. It's important that we not be complacent and that we remind patients that we're seeing outbreaks of many of these vaccine preventable diseases, everything from polio to pertussis to measles. Complacency can happen because of that low perception of risk. So talking about the risks and talking about the outbreaks that are happening within the country is really going to be an important factor. And RSV is definitely one of those diseases that we're seeing an increase in on an annual basis. Confidence. This involves the trust in the safety and the effectiveness of the vaccines, as well as trust in the institutions that recommend them. So we found during the pandemic of COVID-19 that there was a lot of loss of confidence in government, CDC and other groups. And we may have even seen some peripheral loss of confidence in healthcare providers. So this lack of confidence can stem from misinformation, fear of side effects, or doubts about the scientific evidence. And we know that there's so much misinformation that's out there. So as clinicians, we can provide a real service to our patients by talking to them about what it is that they're hearing and providing clarification about the information and the level of risk. And the final thing is convenience. And this is how easy is it going to be for that individual to be able to access the vaccines? So, where are the location of the vaccines? What are our hours of operation? Are they conducive to individuals that are working or that they have shift work or that they are unable to take time off of work? And the cost is always a factor for many patients, especially if they're uninsured or underinsured. There's also the vaccine hesitancy continuum. So continuing to recommend vaccination, even if it's initially declined. I think of that as planting the seed. So I will tell my patients that even if they're hesitant or they're reluctant to get the vaccine today, I will tell them why I think it's important for them to receive that vaccine because of their condition, their age, or why it's important for them as an individual. And then I'll tell them we're going to be revisiting this at a future time. So I just want to tell you up front that I think this is important enough that I would like to revisit this. And then Ruth, I'd like to know, do you face vaccine hesitancy when you're recommending the RSV vaccination specifically?
I haven't had individuals that will point out the RSV vaccine specifically, but I have had patients that will ask me, basically the questions about, will whatever vaccine you're recommending for me, will it help me? Also, will it hurt me? So patients are interested in everything as it relates to them as a unique individual. And I think, there are a couple of take-home messages that I have had from listening to these patient conversations. And number one is I need to do a better job about risk and talking with them about risk factors. And I know it's interesting because, when I go to the provider and I'm doing my electronic check-in, many of us, will fill out paperwork or answer questions before we actually have our visit. And it's interesting that one of the questions I often ask is, how do I rate my health? And it'll say, poor, good. excellent. And, it's interesting because I think, gosh, how do I rate my health? I get up every day, I go to work, I feel pretty good. So that must mean that I'm in excellent health. But then I look and I think, well, shoot, I'm in that older, getting closer to that older adult age. Yeah, I take, medication for hypertension. I also struggle a little bit with my lipid profile. I got a few extra pounds on me. So I do have those risk factors. But if I don't recognize risk in myself, it makes it then very hard for me to have a risk-based conversation with my patient. And I may be less likely to do that. So I have to really remember that I need to be always having that conversation with the patient. So I'm able to convey, why is it that this is important? And I typically start a conversation with my patient. I'm so glad to see him. And, you're the most important person in my whole world right now. Our time together is uninterrupted. I'm going to turn my back on the computer screen. I'm going to turn my phone over. And I want to make this visit all about you. And we have to address a variety of issues during what is sometimes a very limited time. So I have to be very organized. And so how I have these conversations is really going to be led by what the patient is asking and what they're telling me. And I have to be able to make sure that I'm addressing any of their points. So your question was, do patients have a particular question about RSV vaccine? I have not experienced that, but it gives me the opportunity to talk about RSV as a disease of breathing and talk about what then are my patient's individual risk factors. And then I can address then the misinformation that you have mentioned. And I have the opportunity to, use some of the new terms or new words that I have with patients. So, for example, previously, I may have discounted their concerns. But when they bring any type of question to me, no matter how maybe off the wall I think it is, the fact that they are bringing that concern to me, I want to legitimize, not necessarily the actual issue. So if my patient is saying, well, I don't want to be injected with a chip, or I don't want, any vaccine to impact my DNA, I'm not going to say, yeah, that happens. No, absolutely. I know that we don't have the scientific evidence behind that. But what we do and what I do is I say, yeah, wow, I understand, fears or concerns about vaccines. Let me share information that I know. Can I tell you more information? Or many times my patients will say, they'll ask me that, well, what would you do? Or they will ask me a very pinpoint question. Have you received that vaccine? So, this really brings up a lot of important points about how we as providers view vaccines. And are we equipped then to answer those very pointed questions from our patients? So that helps us then maybe think about individually how we view vaccines or vaccination. Because remember, hesitance is not only in one part of our patient population, that all of us have questions or concerns. And Audrey, you mentioned that vaccine hesitance is not a consistent issue, and it may vary both in its intensity and how it impacts a full spectrum of vaccinations and vaccines. And so we need to be prepared to have these questions and then bring them up in an ongoing manner. So just like, if I have a patient that smokes, I'm not going to address smoking cessation just one time. I may bring that up repeatedly. Same thing for vaccines and vaccination, that I realize that if I have a vaccine but I don't get it into the arm of a patient, I've not provided full benefit and full use of that vaccine. So I've got a lot of work to do with my patients in answering their questions about, will a vaccine help me? Will a vaccine hurt me? And I've got to be able to talk about those things, just like you had mentioned, some of the side effects of vaccines. I've got to be able to say some of these side effects, I would recognize that as consistent. So, for example, if I stick you with the needle, I know you may have a sore arm. If I'm administering a vaccine that I expect to elicit an immune response, I need to tell you that it's not going to surprise me if you have body aches or fever. That is part of that antigen antibody response. But I want to make sure that patients are equipped and able to reach out to me if they experience something beyond that. that they know that not only I want to hear from them, I'm enabling them to get back in touch with me, and I want to answer some of their questions. So one of the most common questions now that I get from patients are, well, what about my insurance coverage? And is this going to help me? What are some of those logistical considerations? So I need to have information readily available to patients, and maybe I'll know it. Maybe I will have some basic knowledge about insurance coverage and how that impacts the not only ability of a patient to identify a vaccine, but what about the ability to accept a vaccine? So I know that many of our private insurances, particularly those when I'm talking about those patients that are covered by Medicare and private insurance should cover then vaccines without a copayment. Sometimes our challenge is where can they get it and where will that coverage then be in effect? So this is when I need to make sure that I'm reaching out to my pharmacy partners, that I know then that if I have a vaccine, for example, that is covered as part of Medicare Part D, that vaccine may need to be given either in a pharmacy, or I need to make sure that it is given in a practice setting that has access to that particular type of insurance coverage. So, for example, does your office use TransRx or VaxCare? That may help them then provide vaccines that are covered under Part D, but in your actual practice setting. I also need to make sure that if I am a non-vaccinating office, maybe I don't carry vaccines on site, where do I refer patients? Our federally qualified family health centers, health departments, pharmacies, and others may be those places where my patient can access a vaccine. But just like I need to help my patients develop a vaccination plan, I, as the provider, need to also have a plan in place. Where can I refer individuals? I certainly don't want to tell them, well, just go out and see where you can find it. No, that's not a good answer, is it? And that's not respectful, I think, for our patients who are going to have these challenges. Instead, I need to say, here are some places where you may be able to access vaccine. On the local level, maybe I'm going to include lists. Maybe I've got phone numbers or websites for them. But I need to be able to help them. If I'm helping them, I want a patient to get across the finish line, then I've got to give them information. Now, I know in the U.S., most of our RSV vaccines have been provided in pharmacies. So what is my approach? Do I send an electronic prescription? Do I realize that, well, if I do that, maybe I'm going to send the prescription to Walgreens or CVS, but my patient may remember that they need a vaccine when they're waiting in line at Costco. That we have many of these opportunities. So I've got to enable my patient to access. So I know that when I see them in a practice, they may leave with a printout of that after visit summary. This is when I may say, all right, I'm going to take this highlighter, I'm going to circle. This is what vaccine you need. But I'm also going to remember that that paper may end up at the bottom of their purse or on the floor of their car. So many times now I'm saying, get out your cell phone. I want you to take a picture of this, because you may be in line at Costco or Walgreens or CVS. And I want you to say, oh my gosh, I remember my provider talked with me. Let me pull up my photos in my cell phone. And that may be that additional reminder. So, as a provider, we're having to really think about many ways that we can enable our patients to receive vaccine. So, Audrey, I want to ask your feedback. Do you have vaccine on site, or do you refer your patients, and kind of how do you approach this?
I think, as you mentioned before, that in most of the continental United States that this is Medicare Part D. And so we are having to refer individuals to pharmacies. However, we do try to check in with other practices, including our local health department, to see if they have vaccine that's available. And then, as you mentioned, we provide those resources. I think one of the points that you made is it's really important that we make it as easy as possible for patients to be able to access those vaccines, because otherwise we're going to have a missed opportunity. If we create barriers for them in terms of transportation or coverage, they may be less likely to get this important vaccine.
We mentioned also some impacts about, disparities in vaccine coverage. And, I talked a bit about how do we make sure that we are appropriately conveying risk to our patients so they realize that the vaccine is even important to them. But we may also have areas, particularly areas in our communities that are experiencing high poverty, for example. They may not have a pharmacy. There may be very limited healthcare providers that are there. So actually, their ability to access health services as well as access vaccine may be severely compromised. So, we have spoken, you and I, about, community outreach campaigns and the importance of realizing that, many of these grassroots efforts can be critical for us in terms of reaching our populations, both identifying groups that our individuals trust. You had mentioned previously that, we're all challenged with a loss of trust across every aspect of healthcare. But if we are trying then to make vaccine available in a community where they may have, a lot of barriers, a lot of challenges, it is important for us as providers and really use the power of nurses. Remember, it's a good time, I think, to remember that most every year, the general public will recognize nursing as the most trusted profession. So they're going to listen to us. And they also are going to recognize that nurses are out there in a variety of healthcare settings and that we may be having over-the-fence conversations, maybe conversations at church. We may be, talking in our local communities about vaccination. Let's really think about how to make sure that our approaches are using those elements of cultural competence. We're talking with our patients using verbiage, using language that they recognize. We're talking about accessing vaccine in places where they feel comfortable and confident, that we are doing this all within a very individualized approach to healthcare. That at the end of the day, our patients want to be recognized as an individual. And so it is up to us to use then the strengths and the skills that we have as nurse practitioners, as nurses, to have these conversations so we are able then to drive home this point. So I want to use this opportunity to kind of bring some take-home messages that I hope people will use in our time together. And as they are trying to examine how they view and how they make vaccine available in their settings, how do they establish these conversations with our patients? What are some of these, maybe just a short list of take-home messages for this very important and impactful vaccine, the RSV vaccine? First of all, the RSV vaccine is recommended for everyone 75 years of age and older. For those individuals who are 50 to 74, if they have a risk factor, and remember, that was a long set of risk factors, and I'm just going to pull out, heart failure as an example. Risk factors that are present to both impact how they may struggle with RSV if they become ill, then we need to be having those conversations with them and make sure that there is RSV vaccine available to them. We know that the ACIP drove down the age range for RSV vaccine. In the past, it was age 60 and older. Now it's down to age 50. So that 50 to 74 individuals who have one of those risk factors and 75 and older, those individuals should receive that vaccine. But having a discussion about why they are at risk and why the ACIP is recommending that we don't have to rely on shared decision making. We explain and we have this discussion as part of our routine conversation with our patient about disease prevention and why they may be at risk as an individual. Also, making sure that we are using every opportunity as a vaccinating opportunity, and that may be co-administration of a vaccine. So don't think that we have to just do one vaccine at a time, but we may have patients that are eligible for RSV, COVID, flu, shingles vaccine. All those can be given at the same time, making sure that our staff are appropriately trained so they know how to administer multiple vaccines to a single patient. So clearly our discussion today, Audrey, has brought that we have maybe a lot to learn with RSV and the vaccine. Hopefully our listeners will view this as a good start for them. I hope that we have raised some questions that some of our NP providers then are going to say, I want to think more about this. I want to think about how this will impact my patient. I want to look at my patient population specifically and think about how we can bring then the vaccine to them, the information, as well as perhaps the vaccine itself. Maybe I want to make changes in my practice so I'm able to provide this vaccine in my practice, in my medical home, so that I can then get my patient more easily across the finish line. Audrey, you may have some points that you want to raise, anything that you want to add in our short list of take-home points.
I think you've covered them really well, Ruth. I just want to thank everyone for their participation today and thank each of our participants for everything that they do for their patients, for improving the health and the well-being of their patients and their communities. So it's been a pleasure being here with you, Ruth, and thank you everyone for your attendance today.
I couldn't agree more. Thank you so much, Audrey. It's always a delight to work with you.
Well, thank you so much, Ruth and Audrey. It's been an absolute pleasure listening to you and gaining your perspective and insights on this extremely important topic. To our listeners, I hope you found this episode educational and can apply some of what was discussed to your practice. Join your National Professional Association and add your voice to over 120,000 of your NP colleagues nationwide. I urge you to become an AANP member today. Membership gives you access to so many benefits, including tools and resources for your practice, and the AANP CE Center, which offers a comprehensive library of CE activities for NPs of all specialties and experience levels. Exclusive discounts and many free activities are yours as an AANP member to help you complete state licensure requirements and earn the credits needed for recertification. Be sure to subscribe to this podcast, share with your colleagues, and check back often for new episodes. Thank you for listening today.